All right, so let's talk about prepping your endotracheal tube and getting it ready for the individual that you're going to be assisting with the intubation. So if you're the individual that's going to assist with the intubation, it's going to be your job to prep the endotracheal tube. Notice I've got gloves on. This should be a clean procedure. So as far as getting everything ready for the intubation, you can ask your the individual that's going to be doing the intubation what type of laryngoscope that they may prefer. Remember, you've got the Macintosh blade, which is the curved blade, comes in various sizes, pretty much 1 through 4. You've also got, for the adult population, they obviously go much smaller if you get into neonatal and pediatric. You've also got the Miller blade, so your straight blade. And remember the anatomical differences between the two of these blades. You're going to physically lift the epiglottis with your Miller blade, and you'll place the Macintosh blade into the vallecula, and by pressing into the vallecula, that'll lift the epiglottis so that you can visualize the vocal cords. And these are left-handed scopes, so you'll do the laryngoscopy with your left hand, and you'll do the tube insertion with your right hand. And you want to make sure that when you enter the mouth to the right and sweep left, and you want to make sure that you don't stick the tube down your viewport, because then you're not going to be able to see the port. So you want to take the tube in from an angle and make sure that you visualize that tube as it passes through the vocal cords. And then after you're done, make sure that you close those blades down so that the light doesn't heat up the blade, the metal blade, in case you have to go back in for another look for whatever reason. That way you don't burn their tongue. And then if you've got it, so those are more or less the newer type fiber optic, and a lot of these are disposable, single patient use, so they'll get tossed after each individual use. But you've got some old school ones that'll actually get sent down to be cleaned. So if that be the case, you need to know how to take the prep that, because your blade and your handle are likely going to come packaged separately. So you'll notice that there's a bar right here. You'll want to make sure that you take that and snap it into place. And then a lot of people end up busting their knuckles trying to get that loose. If you just take and hold that, it'll slide right out. And it only goes on one way. So, you know, I mean, it would go on that way, but you're not going to get any light. As far as the light is concerned, if your batteries are good and your bulb is good, it should light up. So you can see with this one that it's not going to light. So I'm going to set that one aside and grab another one. You'll notice this handle's much skinnier, but still has the Miller blade on there. When I close this back to create the electric connection between the batteries, you'll see that the light does lighten up. If you're utilizing an older model laryngoscope, I typically have always taught it the 3 eighths of intubation, or the 3 eighths of your laryngoscope. You want to make sure that you have a light and that it's tight, or it's bright and that it's tight. And I had a student a few years ago say I needed to add another one because you lefty loosey, righty tighty. So the 4 eighths of your laryngoscope is that you've got a bulb, it's you have a light, it's bright, and it's tight to the right. Because if this bulb is loose, it is possible that when you go in for the laryngoscopy to take your view, you might lose that bulb, and that bulb may go directly down to the trachea, and then you've got to do a bronchoscopy to get it out. So make sure that you've got a light, it's bright, and it's tight, turned all the way to the right. And then these bulbs are going to have more of a tendency to get hotter than your fiber optic type laryngoscopes, or the ones that have the LED on them. So that being said, that was a quick overview of your laryngoscope, but you're going to want to make sure that you ask their preference. What style laryngoscope do they want, and what size laryngoscope do they want? As far as the laryngoscope is concerned, a couple things to think about when you are we'll go over that in another video. I just want to stick to prepping your endotracheal tube. Your endotracheal tube is going to come packaged. You can ask what size endotracheal tube that the person that's doing the intubation wants. For the most part, as far as the MBRC is concerned and what our books keep in mind, is typically for your average size adult woman, you can do a 7-0 endotracheal tube. For an average size adult man, an 8-0 endotracheal tube will work. In my experience, I have found that when I do an endotracheal intubation, I can get a 7.5 just about in everybody. Now you want to make sure that you go up, because you have to keep in mind when we go over mechanics of ventilation and everything, you've got to understand the smaller the tube, based upon Poisson's law, you're going to increase your airway resistance quite a bit. So you want to, I would try to maximize the size endotracheal tube that you can for the purposes of having a better conduit for ventilation and the movement of air in and out of the lungs, or the movement of your therapeutic gases in and out of the lungs. So these should come packaged, they're sterile. You really want to try to keep from touching this, and you don't have to wear sterile gloves because you can keep it clean, but you want to make sure that you keep it as clean as possible for the patient. So what I would do is I would tear that open enough so that I can pull my pilot tube and pilot balloon out. This pilot balloon is going to go down to the cuff. There's a cuff on the tip of this endotracheal tube that once you get it seated in the airway, you'll fill it with air, and that cuff's going to open up and seal off the trachea so that there's not any, so that gas just goes into the lungs and right back out of the lungs, and there's no leak around that. So before you put one of these tubes in, an endotracheal tube in a patient, it would make sense that you would want to test that cuff to make sure that you have a functioning cuff, because if the cuff doesn't function and you didn't test it before you do the intubation, then you may have to extubate and re-intubate and put the patient through the trauma of having the laryngoscopy procedure done twice. So typically what it'll do, just take you you can do a 10, I happen to have a 20 cc syringe here, take and fill that cuff up, and you can see that that cuff did inflate. I can squeeze it here, and I see that the cuff remains inflated. So now that I'm prepping those materials, I'll go ahead and withdraw all of the air out of the cuff. Go ahead and withdraw all the air out of the cuff, that way it's there, and the tube is still clean on the inside of the package. You can leave this out. Some people have a difference of opinion on whether or not to do this or not. Any intubation that I've ever prepared for or set up myself, I've always attached my syringe, and you got to make sure there's a one-way valve inside of this pilot balloon here. It's a one-way valve. You got to make sure that you unseat that valve, so you want to make sure that you stick that syringe in there nice and tight, and then you can leave that on for the duration of the intubation procedure. That way, once you visualize and get the tube in, you're already connected and ready to go for inflating your cuff. So depending upon preference, some individuals utilize a Stylet, some individuals don't. I am of the company that utilizes a Stylet, so you can set this aside. Your Stylets may come in different shapes and sizes or what have you. These have obviously been used a few times. It's important to note, I'm going to use a tube that's already been opened, but when you do insert your Stylet, it's important to make sure that the Stylet does not extend. So if I were to undo that a little bit, make sure that the tip of that Stylet does not extend beyond the tip of your endotracheal tube, or better yet, Murphy's eye that's on that endotracheal tube right there. So I would back that up just to about right before the Murphy's eye, and then you can fold that over the hub of the endotracheal tube. That way your Stylet doesn't slip down. And then you can put a little bit of a bend in the tip of your endotracheal tube to facilitate being able to pass that through the vocal cords. So if I'm setting up for a brand new intubation, I'm going to use brand new equipment. So I've got the brand new tube. Another thing that I'll mention here shortly after we get the Stylet in. So you get you a brand new Stylet, and you'll open the Stylet up. This Stylet will get inserted into this brand new endotracheal tube. Again, make sure that the tip of that does not go beyond that Murphy's eye or toward the tip of the Stylet, and then you can take this and bend it around the hub. That way that will not go in. Now obviously that was straight, so I can put a little bit of a bend in it, and I will here shortly. you're going to be manually ventilating your patient, so you may have a lot of dry gas that's going down, and that may tend to dry things up as far as the cords. So you want to make sure that you lubricate the endotracheal tube so that it slips and slides nicely through the vocal cords. So you take your sterile pack of lubricating jelly, and ultimately what you'll do is squirt that inside of your package. And now you can take this part of the tube, run it around the tip of your endotracheal tube, all the while that tube is still clean. And now that you've got it lubed up, you can put a little bit of a bend in that tube and be ready to go. Because the laryngoscope is a left-handed scope, I would orient myself to the right of the individual. The individual that's doing the intubation is going to be standing at the head of the bed, or they should be standing at the head of the bed, and they'll be utilizing bag valve mask ventilation. That way, because if I'm on their left side and I'm prepping everything, I've got to reach across them to hand them stuff, or reach across them to do stuff. And once you get your eyes on the prize or the vocal cords, you want to make sure that you don't take those off of there. So I would orient myself as best I can to stand on their right side. That way everything that I'm doing is not crossing their face, but within their peripheral vision, so that you're able to set that up. You also want to make sure that you've got suction ready to go. Have a tonsil tip suction device or a yonker. I'm in North Carolina, so in the southern states, so we call it a yonker, but I had someone that's from New Jersey and they corrected me and said the correct pronunciation is yankower. But make sure that you've got a tonsil tip suction device or yonker ready to go for the purposes of suctioning out vomitus or anything else that may be there. You also want to make sure that you've got an end-tidal CO2 detector ready to roll. That way it'll do its color change and can help you verify that you have the tube in. So that's getting set up and ready to roll for your patient. So make sure that you've got the tube ready to go, keep your syringe ready, and make sure that you have the blade or blade handle that they want. And you can hand the blade handle to them when it's time to remove bag valve mask ventilation after they've been hyperoxygenated with 100% oxygen for a couple of minutes. Then they're going to actually begin. Then once this blade goes in, the 30 seconds clock starts. They'll go in, they'll get their view, you have the tube ready to roll, hand it to them, they'll put it in, they'll hang on to it, secure it. Then, or before it's secured, you want to make sure that you're assessing placement. So end-tidal CO2 will go on with the bag valve mask, and I'm going to do another video to demonstrate that as well. But that's what you'll need to have set up and ready to go for the tube. In addition to that, you're going to want to have either a commercial tube holder ready to go, or have your tape already pre-cut. So if you were going to have your tape pre-ripped and ready to go as well, because once a tube goes in, you're going to want to secure it, and it's nice to have everything done ahead of time. And I will do a taping video here shortly, but you go ahead and have your tape split and ready to go. That way, when it's time to tape the tube, you're not having to go through and do this after the intubation's been done. That way you can kind of, because there's going to be lab coming in, chest x-ray is going to be coming in. They may be trying to get IVs if you're in a code situation or what have you, because, you know, if you happen to work in an OR environment, it's a bit more controlled, you've got more time. But if you're working in a critical care environment, in an emergency room, ICUs or what have you, you know, a lot of stuff happens. So if you can, the best you can prepare a little bit more, then you're ready to roll. So that's it for this video.